Hey folks, you're listening to The Poison Lab, a show about poisoning from people who manage poisoning. And I'm your host, emergency medicine pharmacist and clinical toxicologist, Ryan. Now, today is a different type of episode than normal. It's not our usual deep dive into the history, science, and management of a poison. We invited on a guest, a clinical mentor, friend, and colleague of mine. Today is just two people with a background in managing emergencies and poisonings, as well as pharmacokinetics and pharmacodynamics, attempting to answer some of the many unknown questions about toxicology that still exist, and having clinical discussions around some cases of severely poisoned patients. Full disclosure, some of this is entirely theoretical, no evidence beyond our own brains trying to think up answers. But we do our best to support statements with evidence when we can. So the first half of the show, we're going to answer some questions from, the internet. Unfortunately, most people asking questions on the internet are asking about how to use illicit drugs. It should be no surprise to you that a toxicologist's workload often involves managing the toxicities from said illicit drugs in patients who are using them. So while we use these questions as a platform to address the pharmacologic and theoretical considerations behind the questions, we are not advocating for anyone to use illicit drugs. It exposes any user to risk of serious health effects, contaminated products, and unregulated doses. If you are struggling with a substance use disorder, please check out samhsa.gov or call 1-800-662-4357 for a free information line to help you find the treatment that you deserve. With that said, we will be covering a variety of topics. What causes false positives for fentanyl? Why do certain drugs have paradoxical effects, where higher doses seem to have actually a diminishing effect? Are people ingesting illegal tryptamines like LSD at a higher risk for severe toxicities such as Serotonin Syndrome if they're already on a serotonergic agent? Or what is the baseline risk anyways? Is that something we can measure? Then, during the back half of the episode, we review some cases of severe poisoning and discuss the differentials for what could have caused these toxicities. Now, I know there's a fair amount of non-medical listeners to this podcast, so I wanted to give fair warning. There's no plain language summary. We use the full medical jargon. So you might get a little lost today, but it might still be entertaining to listen to, and hopefully you can hear a little bit more about the kinds of things we think about when addressing these questions. Now I have to apologize for something. The microphones did not cooperate during the entire show. So there are some spaces where the sound jumps around. I'm sorry about that. If you are an audiophile, prepare to be offended. Promise we'll fix it for next time. Okay. Without further ado, let's roll the episode. Hey everybody, this is Ryan, your host, clinical toxicologist and emergency medicine pharmacist, and you are listening to The Poison Lab. And today we have a special guest with us. Toxo is unplugged in the closet, not hanging out with us today. Today we have the one and only Matthew Stanton with us. PharmD, BCPS, DABAT.
Happy to be here.
This is a welcome guest. Matt is a clinical mentor of mine. He was the first pharmacist trained in Wisconsin to take the diplomate of the American Board of Applied Toxicology exam. So he's the first clinical toxicologist trained out of Wisconsin. Matt works as an emergency medicine clinical pharmacist. He's also an assistant professor, Division of Emergency Medicine and Medical Toxicology, and a practicing clinical toxicologist helping to manage poisonings and overdoses. And just thrilled to have him here today.
Thanks for the introduction. I'm happy to be here.
How's it been since saw you 2 hours ago?
Been good.
2.5 hours ago. Matt and I just spent the last few hours teaching our new learners, our new PGY2 EM pharmacy residents. We had EM boot camp today, where we ran some mock patient drills, which is a good time. Putting our residents through the ringer in terms of some of the disease states they might encounter in the emergency department, like arrhythmias or, shock, resuscitation. I thought it went well.
No, I think it did too. I think it's a great idea. I mean, we worked in some teaching points and, it's like quick and it's EM and tox and like, you got to think on your feet and like, it's It's fun stuff, I think.
All the fingertip knowledge you need in the ER.
Oh.
Yeah, no, I think it's helpful. Oh, I got some news for you.
What's that?
Well, we'll see if this is still relevant by the time this comes out. But, well, you are familiar with the outbreak of vaping-related pulmonary injuries, e-cigarette and vaping-associated lung injury, or EVALI.
Yeah.
Well, they just arrested somebody who was distributing $2 million a month of THC vape cartridges associated with e-cigarette and vape-associated lung injury. Do you want to know where they arrested him? Did I tell you this already?
No, but they arrested some people down in southeastern Wisconsin, didn't they?
Yeah, no. Well, I guess you could call this southeastern Wisconsin because it was one floor below me.
No way. Are you kidding?
I know. It was insane.
What?
Well, they originally arrested this person about a mile from me, and then when they got arrested, they, I guess, got evicted from their apartment, and then moved into my building. And then they wrote the Wall Street or Wisconsin Journal Sentinel, whatever, picked up a story about it. And they wrote in the story, they were talking about e-cigarette and vape-associated lung injury. So for those who don't know, Matt and I have been tracking this outbreak pretty closely. We've co-presented webinars on it a couple of times, and we're doing a research project and we've published on this. But anyway, so this guy gets arrested, and they run this big news story about it. Guy selling illicit vape cartridges that may be linked to the EVALI outbreak, and they look for a health official to give a little piece about how vapes can actually affect your health. And who do they ask? The State Department of Health Services, John Myman, who's the co-author with us on a paper about what the source of EVALI could actually be. And the source was one floor below me.
Holy cow. What do you call that when it's
ironic? I have literally interviewed patients about what kind of vape products they use, where they get them, and turns out it's from my neighbor. So it's a little Breaking Bad-esque, I would say.
That is, wow.
Anyways, welcome to the Poison Lab. We're going to be doing something a little bit different than normal. Normally, we tackled some subjects. There's really not a set, I guess. There's no real set plot for these episodes yet. So we're still finding our voice, finding what people like. But today we're going to do something different. Today is going to be, we're going to do some clinical cases. So Matt and I are going to bounce a couple clinical cases off each other. We're going to try to hide what the toxin is and see if the other person can guess it. And we're going to source these cases from fatality reports that have been published in the American Association of Poison Control Centers. And I think it's good learning, listening to the differentials. Not trying to make light of any fatalities, but it certainly highlights that some of these things can be super toxic. And then we're going to do something else, which is called Toxicologists versus the Internet, where we do our best to answer some questions from reddit.com, the subreddit Ask Drugs, because there are some really wild questions that show up on that board. In fact, Matt and I actually tried a version of this earlier. We've actually recorded an episode like this before. The audio didn't turn out, unfortunately, but we really got derailed right away because one of our first questions about the internet was we found someone who took 15 grams of Tylenol and they had just posted it 3 minutes ago and they were wondering if they would be okay. So we went on a deep dive convincing that person to go to the ER. And as it turned out, they lived in a country halfway across the world. But fortunately, they did go in and seek medical care. But that threw us through a loop. So this time, instead of just choosing random questions, we have each pre-selected a question unbeknownst to the other and decided we're going to pitch them at each other and see what we end up going with. So what do you think we should start with, Matt? You want to do cases? Or you want to do some internet questions?
Let's start with cases. The internet questions can be a bit of a gamble sometimes. So
a bit of a gamble. Well, I kind of had a plan that we were going to do internet questions first.
Okay.
I'm just excited to hear you tackle these questions, man. Is that okay?
That's fine.
I already have some lined up. Here's a question from reddit.com, Ask Drugs. False positives for fentanyl. It says, I have been sober since October 31st, 2018. And today I tested positive for fentanyl. Does anyone really know what could cause a false positive for this drug? I don't see a lot of information on the interwebs about the possibility of this. And to be honest, it's really starting to make me nervous. If anyone has any knowledge on the subject and could help me find the answers as to why or how this could have happened, I would really appreciate the help. Thanks, Reddit. All right. False positives for fentanyl. I don't know. What are you thinking, man?
Obviously, aside from potential fentanyl derivatives, I mean, nothing comes to mind as far as false positives for this. I'm also wondering about the methodology of the testing that's happening here. I mean, our institution doesn't use immunoassay fentanyl tests. I'm not sure how many other places out there do.
I don't imagine that there's some.
Yeah, I mean, probably. I mean, that's a fantastic question.
All right, I did a little research. So you're right for half of it. Obviously, you got to consider the fentanyl analogs. So I'm assuming it's probably a urine drug screen. And if this is like a clinic, it's probably an enzyme-linked immunoassay urine drug screen. So for the listeners, I think we've gone over this before in other episodes, but immune assays are, you're using essentially an antibody that is designed to target a specific fragment of a molecule. And certain other molecules can contain those fragments and look enough like it that it'll trigger a false positive. So for instance, pantoprazole, which is an over-the-counter stomach acid medicine, triggers false positives for THC. Same with naproxen. There's enough similarity in their chemical structure that this enzyme is a little bit blind to it. It is not a super specific assay. It's also somewhat insensitive too. So something with enough structural homology to fentanyl could, in theory, trigger a false positive. So I did find one study. Oh, wow, this is fascinating. So I found one study that looked at false positive to fentanyl immunoassay, which would be like a urine drug screen. And they said, all right, first off, acetylfentanyl would obviously cause a false positive because that's a fentanyl group with just a single acetyl group added to it. But this is really interesting. Risperidone can cause a false positive for fentanyl.
What? Really?
Yeah. Of course, it depends on which enzyme-linked immunoassay manufacturer. But now look up the structure of fentanyl. So fentanyl will not typically trigger an opiate urine drug screen because usually they're looking for a morphinan or some kind of structure that's really common to the actual opiates that are derived from the opium poppy. But fentanyl and Risperdal
not have a morphinan structure.
I'm kind of blown away by this. Well, I see fentanyl has this 5-carbon, 1 nitrogen, 6-membered ring, which is called a piperidine ring. And that is attached via the nitrogen group 2 carbons away from a benzene ring. And risperidone has the exact same piperidine group located 2 carbons away.
Oh, yeah.
Attached by the nitrogen to, it's not a benzene, but it is a 6-membered ring with a carbon-carbon double bond. So I can see the structural homology here. I mean, it looks exactly the same. Now, the study actually is telling me that this structural homology that their enzyme-linked immunoassay is attacking on risperidone that fentanyl also is called an alkyl piperidine.
It is.
So they both have it. So that's kind of interesting.
Now you have me thinking, though. You've piqued my interest with risperidone. So since paliperidone or Invega is the metabolite of risperidone. Would paliperidone also probably give you a false positive?
Well, let's see here. Because you asked, they actually said that risperidone and its metabolite, 9-hydroxyrisperidone, were found to cross-react with fentanyl immunoassay. Now, is the 9-hydroxyrisperidone the same as paliperidone? Hold on. Gosh, you are too smart for your own good. Yes, that is the exact same thing. Paliperidone is 9-hydroxyrisperidone. Wow, fascinating. Here, I'll put the study in the chat. So, okay, good internet user. If you are on risperidone, that might be what's causing your false positive for fentanyl. Talking about all the structure, it's actually a good reminder. So, there's piperidine in fentanyl. Piperidine derivatives are used for a lot of antipsychotics. It's a good way to remember that, fentanyl is actually a pretty serotonergic drug. And there's some case reports of fentanyl-induced serotonin syndrome out there. So, nice little caveat. All right. You got one for me?
This might be a tricky one. I haven't seen this drug in a long time, so it caught my eye. Carisoprodol Timeline is the title of this post. So, carisoprodol is a substance that is very odd. Sometimes I take 750 milligrams and feel an intense euphoria after 30 minutes. And sometimes I take 1,500 milligrams, which was double the 750, what this person said, and feel mild effects. Why does this happen? Also, is there a delayed onset? It's hitting after 2 hours or more.
Well, let's go ahead and just assume positive intention and that this is a prescribed medication, because if it is not, they just shouldn't be trying to take it at all. How about that? So they're wondering why there appears to be a delayed onset in the effect and a paradoxical reduction in activity with increasing doses. Is that correct?
That is, yes, that's a great interpretation.
That is interesting. Now, this is Soma. This is an old school drug.
The brand name, it's sold under the brand name Soma.
According to carisoprodol's Wikipedia page. So it's actually a carbamate. Oh, I guess it's related to some of our favorite insecticides. Okay. Now, its actual mechanism, I think this is one of those drugs that is so old that we just accept that it works and we don't know its mechanism. People are like, oh, muscle relaxants. There's so many quote unquote muscle relaxants out there. Diazepam, tizanidine, you have probamate, metaxalone. None of these are actually muscle relaxants. These are brain relaxants. The only real muscle relaxant is a paralytic, like Rocuroni. So these don't really help you relax your muscles. They kind of just make you care less that your muscles are spasming. Now, there was, a whole slew of research, I think, back in the 70s. They looked at the antispasmodic properties of benzos and et cetera. And, okay, whatever. In the end, they all just make you sleepy. Now, what is the actual pharmacology of this drug? Let's see. All right, the mechanism of action that they supply and up to date, not yet clear. But many effects have been ascribed to its central depressant actions. It blocks interneuronal activity, and depresses polysynaptic neuron transmission in the spinal cord and reticular formation of the brain, and is metabolized by CYP2C19 to meprobamate. Okay, not a super helpful mechanism. Now, I don't think that at higher doses, we lose receptor selectivity, like with some other drugs. For instance, mirtazapine, at a lower dose, we use it for its anticholinergic effect, but at higher doses, we start to get some stimulating effects because it loses its receptor selectivity and it starts to hit more of the, causes more release of adrenergic neurotransmitters. Or opioids, which are kind of stimulating at low doses, but then at higher doses are sedating. And I don't think it flips into a partial agonist at a higher dose, which is sort of what they're inferring here.
Yes.
Where increasing dose leads to decreasing receptor stimulation. Probably has to do much more with other properties than this person's specific dose that they're taking, like whether they have co-ingestions involved. So it's a sedative. Obviously, if you have other GABAergic drugs on board, like ethanol or benzodiazepines, it's going to have a synergistic effect. That might be an issue. Probably has something to do, if I had to bet, the kinetics of absorption might be altered. Well, I guess we don't know. My guess would be either she has variability in her CYP2C19 meprobate production after taking a cardiazepam. Perhaps she was on an inducer at one point, and at this point she is off, and thus having different effects. Or there's some kind of effect from absorption that's leading to significant alteration, or it's patient-specific factors with each unique encounter with the drug that change the amount that she's requiring. That's my guess.
Nice. Yes, that's. I mean, So when I read this, I was first taken aback by someone's trying to use carsoprotol, which, I mean, like you mentioned, some of these muscle relaxers, quote unquote, probably work more at a central nervous system level, and it's not, a clear muscle relaxant per se. Granted, if you're sedated or if there's enough anxiolytic on board, you're not going to be contracting your muscles like you usually would. So there's possibly some indirect muscle relaxant in some way. I didn't think about the absorption or the 2C19 metabolism to meprobamate, but those are pretty interesting observations.
I think it was, I have a couple of friends who used to work at the Walgreens on the Vegas Strip. This was part of the Vegas cocktail. Soma, diazepam, and it used to be Norco, but now it's tramadol.
Wow.
These are all the drugs that their primary care provider could call in over the phone because they were not scheduled to.
Wow.
Wow. All right, I got one more for you, and then maybe we could jump to case. Does that sound okay?
Yeah, that's fun.
How do I make LSD? What? What is the process of making LSD? I love the first comment on that post. All right, this is not the question, but the first comment on that post was, if you don't know how, you shouldn't be trying. If you're asking this question, you should not be trying, which I have to agree.
Let me call Alexander Shulgin for you.
Let me call Albert Hoffman. So here is the next question. I'm currently on a low dose of Prozac, 40 milligrams daily. I have tried LSD before. I was taking an SSRI and it was great. I want to try it again, but I'm not sure if it's dangerous. How likely is serotonin syndrome if I mix them? Is it super dangerous? Does anyone have experience with mixing these drugs?
Well, unfortunately, I don't have, or fortunately, maybe, I don't have experience mixing either of those drugs or using them by themselves.
This is just always the question. When we get calls about these LSD or dimethyltryptamine or psilocybin, how many of them are going to get serotonin syndrome? We get this all the time in terms of ingestions. And I'm always thinking to myself, all right, well, are these guys at a higher risk of serotonin syndrome that I'm going to have to deal with clinically? So let's say you get a consult. You have a kid who shows up in the ER. They're on fluoxetine or whatever, SSRI. And they're a little bit agitated because they just took LSD, and you get a call from the ER and they're saying, is this kid going to develop serotonin syndrome? Do I need to send them to the unit to obs them and make sure they don't get clonus or hyperthermia? What do you think?
Well, I think it just depends on their presenting symptoms. I mean, probably, mild serotonin toxicity, I think might go unnoticed.
Right. That's why I think there's no way to do a point estimate of how likely it is to develop serotonin syndrome on really any drug, because it's going to be missed in most clinical cases.
Yeah. I mean, unless there's spontaneous clonus, or if someone does, try to induce lower extremity clonus, it might get missed sometimes. I think this gets back to, the old toxicology adage of the dose makes the poison, right? I mean, it's highly unlikely with a single substance like fluoxetine that you're going to get severe serotonin toxicity. Obviously, your risk would likely increase with the addition of another serotonergic agent.
Right. Multiple mechanisms of serotonergic stimulation is what I really think of as the highest risk. I definitely worry about it with MAOIs because
Yeah.
you're increasing serotonin release, reducing its metabolism, and increasing stimulation.
And clinically, I rarely, will see, especially single drug, even if it's large amounts, I think it's pretty rare to see severe serotonin toxicity. Again, maybe they have some mild serotonin toxicity and it's just, we just kind of don't recognize it or call it that, because as much as I would love to fit all these patients in a box, I don't live in the absolute world anymore. It should be thought of more of a spectrum, right? You have mild serotonin toxicity, moderate, severe serotonin toxicity. Now you can consider, anyone with a neuromuscular abnormality, a altered mental status, and some autonomic dysfunction, and you can use the Hunter's criteria. I would prefer to call it just severe serotonin toxicity.
So I think what you're saying is it's impossible to estimate someone's true risk. You need to just look at the patient in front of you, and if they have symptoms, well, then they're more likely to develop more. Here's my question: what drugs make you scared of serotonin syndrome? What would they need to take? Are you more worried about serotonin syndrome with methamphetamine or with LSD?
Probably. I think probably amphetamines. Yeah.
Just think of a meth agitation. You're hyperthermic, tachycardic, add in a little Clonus, and you got serotonin syndrome.
Yeah.
The first case I ever saw was a bad meth ingestion. A lot of people forget those have potent serotonergic properties.
Yeah, assuming a HT2A.
Oh, that is the perfect segue for the research that I did for this little question. Okay, so which serotonin receptor needs to get stimulated? You have something like 7 different serotonin receptors, and each one of those has subtypes in them. So you have 5-HT1, 5-HT2, then you have 5-HT2A, 5-HT2B, and it goes on. I think there's something like 30 serotonin receptors. So which one is actually most correlated with serotonin syndrome? And that one, I believe, at least in animal studies from the last review I read, the 5-HT2A receptor is the most associated with development of hyperthermia. So that's kind of thought to be implicated. What I found really interesting is that LSD is actually only a partial agonist at 5-HT2A.
Wow. I did not know that.
Which that makes me wonder, is this going to be able to create as potently serotonergic of an effect as other tryptamines? It is incredibly potent in terms of its affinity for the 5-HT2A receptor. So if you actually looked at the binding affinities, the dissociation constant for LSD is 0.004 micromolar. Do you think people would know what a dissociation constant is?
I don't know. Who's listening to this podcast?
I don't know.
If people should be curious. If they don't know what it is, they should look at it.
You think somebody's going to look something up afterwards? They're probably lucky that they're listening this far.
Yes, you should. Yes, you should explain what it is.
All right. Well, we'll keep it really simple. When pharmacologists do their cool, binding studies, it's the amount of drug that they have to add to a solution to displace another drug that's binding a receptor. So, for instance, let's say you have like something that's binding the 5-HT2A receptor. It's how much LSD I have to put into solution to knock 50% of that binding agent off the receptor. So if I don't need very much LSD, it means it's super potent for that receptor. So the lower amount you need, the more potent it is. So the Ki for, so I found a nice review that shows the Ki for LSD for the 5-HT2A receptor is 0.004 micromolar. For context, other tryptamines, such as dimethyltryptamine, the active ingredient in ayahuasca or whatever, businessman's lunch, Joe Rogan loves it, the Ki for that is 0.04, so 10-fold less potent than LSD. Other drugs like psilocin, which is the active ingredient in psilocybin, has a Ki for the 5-HT2A of about 0.25. So that's about 100-fold less potent than LSD at the 5-HT2A. And things like MDMA or what phenylethylamine. So, for instance, mescaline is a phenylethylamine, which is more in the class of they more mimic catecholamine, so are more adrenergic drugs like MDMA. The Ki for that drug is 6.2. So micromolar. So that's nearly, a few thousand-fold less potent than LSD for the 5-HT2A receptor. But LSD is a partial agonist.
But now you have me thinking even more. If it's a partial, analogous to a partial mu opioid receptor agonist like buprenorphine.
Yeah.
If someone has serotonin toxicity from, let's hypothetically say they could get it from their prescriptions or their SSRI, including linezolid or an MAOI or what the case is. You give LSD to them, will that block it and reverse?
Would it actually reduce their effectiveness? Now, the other thing I would think is that if you're chronically on an SSRI, do you have downregulated 5-HT2 receptors? You probably do, because you're inhibiting serotonin reuptake, so then your 5-HT2 receptors postsynaptically are chronically stimulated, and you'll probably downregulate. So you probably need a higher dose to get serotonin syndrome.
Yeah, that is
at least the theory. Like as we said, this is not evidence-based. It's probably vastly more complicated than the theory. The fact that 5-HT2A is associated with serotonin syndrome. I mean, I know there's other neurotransmitters involved, but that's interesting to think about. But interesting topic. We're not condoning that person use LSD at all, but the interaction between those drugs could warrant more study. And truly, I'd love to understand from a clinical bedside management perspective, how often is serotonin syndrome occurring with these tryptamines?
Toxo here, reminding you that these discussions are entirely theoretical and are simply an interesting way to apply pharmacologic concepts to simplified models of a complicated disease. These discussions are not meant to imply that certain illicit substances are safer than others, and the hosts are not encouraging their use. Taking any unregulated illicit substances with potent psychotropic effects poses serious health risks and exposes users to unregulated dosing and potentially contaminated substances. If you are struggling with substance use, visit samhsa.gov or call 1-800-662-4357 for help finding treatment.
Anyway, so I thought those were some interesting things, and they bring up some fun talking points. But do you have any more you wanted to dive into?
No, that we can save them for later episode.
All right. Well, then maybe let's go on to the clinical cases.
Yeah.
So the way we're going to do this is that one of us is going to read through a clinical case without giving away what the toxin is. So the goal is for the guesser and the people listening along at home to try to identify the toxin based on the signs and symptoms of exposure, or possibly learn something by listening to our toxic differential while we talk about the exposure. And hopefully be able to identify and treat these toxins in one of their own patients, should that unfortunate event ever occur. Okay, you ready for your first one, Matt?
Yeah.
Hey folks, it's Ryan. I wanted to take a minute to talk about something before we jumped into the cases. You are about to hear Matt and myself discuss some cases of fatal poisoning. We were not involved in the care, and the only information we have comes from anonymously written case reports from an annual scientific review of poisonings that anyone can access. For us and those listening, we have no connection to what happened, which can make it easy to be detached from the true tragedy that occurred. Like when you hear about a death from the distant past. So, while these cases, to us, are stories that teach the severe manifestations of poisoning, to others, these were real people that tragically lost their lives too early due to the toxic effects of poisons. So we wanted to take a moment to express our sadness for anyone, patients or loved ones, who have been affected by poisoning or overdose death. While these outcomes are not what we would like, we are grateful for the valuable lessons that they teach us. And we hope that by reflecting on these cases, we may prevent the same outcome in the countless others that are exposed to these same poisons each year, as all poisoning deaths are preventable, and even one is too many. Secondly, patients that we're about to describe took some of these substances with an intent to harm themselves. which might be disturbing for some to hear about. If you have ever contemplated suicide, someone is here to help. You can call the National Suicide Prevention Lifeline at 1-800-273-8255. Somebody cares about you. Okay, let's hear about the cases. 40-year-old male presented to the ED after 4 days of use of this substance as a weight loss supplement. He was unresponsive with dilated reactive pupils, high blood pressure, tachycardic to 130s, and temperature was 40 degrees Celsius. His labs were essentially normal, but he did have hyperkalemia to 5.6, a bicarbonate of 18, anion gap was 12. His BUN was 66, creatinine 1.6. His CPK was 6291. Mm-hmm. His lactate was normal. Calcium was low. He had some liver sweat going on, AST, ALT elevation. His ABG showed a pH of 7.2. He had a PCO2 of 49 and a PO2 of 180. EKG showed sinus tach with some PVCs. Mm-hmm. Patient was intubated and aggressively cooled. Received IV fluids, benzos, and dantrolene. On day 2, temperature was 37. He remained unresponsive, required vasopressors, developed acidosis, and worsening kidney function despite bicarbonate. Family opted for comfort measures, and the patient passed away on day 6. So showed up hyperthermic, tachycardic, and a little bit of rhabdo, taking something for weight loss, intubated and cooled, but progressed to renal failure.
All right. It's a good case. No, unfortunate. Was it a weight loss supplement, or did it say something for weight loss?
It was a weight loss supplement.
It was a weight loss supplement. Okay. So every time I think about weight loss substances or substitutes or substances for weight loss, there's a few things that pop in my head. One is always caffeine. It's one of the most widely used drugs. It's easy to get.
Oh, yeah.
Easy to drink in coffee.
I just had some.
Yeah. So that's one of the first things. However, when I think about cases like this, caffeine being a methylxanthine, obviously you can get tachycardia. You can get hyperthermia. I expect hypokalemia when I think of methylxanthines, though.
I'm with you there.
And I don't think, from what I heard, I don't think this patient was hypokalemic.
No, they were hyperkalemic.
Other weight loss supplements, I think of some other stimulants, whether it be amphetamines, prescription amphetamines, or illicitly used amphetamines. And
of course, the weight loss prescription, phentermine, taken off market for a while for causing heart attacks and coming back in.
Ephedrine, is a classic one that there were major or professional athletes even using. So it's possible. And again, you'll see tachycardia. And anytime I hear a tox patient with that's hyperthermic, that's usually what scares me the most, and that's what usually we have to address. So aside from infection and possibly other causes of fever, I think of stimulants. I think of methylxanthines. I'm assuming this patient's not going to be on theophylline, and it's probably not a weight loss supplement. My other concern is, and especially with a death, is dinitrophenol. That is probably going to be my guess. And you can think of other uncouplers and that's basically what dinitrophenol does, right? It messes up the proton gradient, makes ATP energy production, less efficient. As far as oxidative phosphorylation goes. And there's a lot of other drugs that do this. Salicylates can do it as well. So,
the bodybuilding community, that's something like the ephedrine stack. You're supposed to take aspirin and ephedrine to increase your fat oxidation and increase energy consumption. So dinitrophenol Normally, you make energy after you store it as potential energy in the form of hydrogen in the mitochondria. And then the hydrogen shuttles across the mitochondria and you store it as ATP, and then you can use that ATP, which is to move your muscles and etc. Dinitrophenol allows hydrogen to just flow through the mitochondria without storing any of that potential energy as chemical energy. So then you have to release all the energy and it gets expressed as thermal energy. And that's what we get hyperthermic patients. Somebody described it really well to me. Probably heard it honestly in another podcast, but dinitrophenol is like putting your car in neutral and revving your engine as hard as you can. It's going to heat up. You're still burning everything. You're just not going anywhere.
Yeah, it's a great example. I like that.
This was a bad case. I mean, you hit it right on the nose. All the really interesting stuff about dinitrophenol wasn't really in this case. It makes you yellow, like Homer Simpson.
Oh, yeah, that's.
And additionally, the fascinating aspect, they don't talk about what they were paralyzed with for RSI, but so there's this concern that if you paralyze somebody with succinylcholine, which is what we call a depolarizing paralytic, so you remember you can't make ATP when you're on dinitrophenol. You're really bad at it. So you can be ATP depleted. You actually need ATP to relax your muscles, not contract it, which is why people go into rigor mortis when they die, because they run out of ATP after the muscles have contracted and you don't have any energy to relax the muscles. Well, if you're on dinitrophenol and we give you this medicine, succinylcholine, which forces you to contract all your muscles, you can go into early rigor mortis while you're still alive, which is terrifying. And that's usually accompanied with a massive spike in your carbon dioxide levels, severe acidosis, hyperthermia, and usually death. These are scary drugs. Yeah.
Very scary.
Well, anything else you would have done for that patient? I mean, moved and cool.
Aggressive cooling, was one of the, and again, with any tox case that is hyperthermic like this, aggressive cooling, not just using a cooling blanket, but convection and evaporation with water and fans. If you get an ice bath, that's probably one of the fastest ways to cool somebody.
Yeah.
You need aggressive cooling measures, and that makes for scary cases sometimes.
From how they're describing this case, I think the patient presented a little bit too late. Seems like they arrived with unresponsive dilated pupils. They already had a CPK elevation, which I'm sure you developed rhabdo earlier on dinitrophenol, but it makes me think maybe that they were down for a while. They're hyperkalemic. I don't think they showed up walking and talking. So my guess is prognosis was already poor when they arrived, even though they did effectively cool him. It continued to develop worsening renal function and probably had CT that demonstrated some poor prognostic signs and called it at that time. All right. Nice work, sir.
Very interesting. I like this. All right. Are you ready?
Mm-hmm.
Okay. So the scenario, a 53-year-old female presented with methemoglobinemia after chronic abuse of this substance.
Poppers.
Past medical history is chronic UTIs, a recent admission for methemoglobinemia.
Oh, phenazopyridine. Anyways, keep going.
Physical exam appeared jaundiced, confused, blood pressure of 154/77, a heart rate of 108, respiratory rate of 16, O2 sat was 78%, which was 100% on a non-rebreather, and temp of 37 degrees Celsius. Methemoglobin level of 46. An ABG was drawn with a pH of 7.32, PCO2 of 44, PO2 of 67. Hemoglobin was 9.2. On day 2, her potassium was 9.3, creatinine of 3.1, the lactate of 11.2.
Wow. All right. Well, I think I've got some information that I need. So first off, I've got a jaundiced, confused 52-year-old with a methemoglobin of 46% and a hemoglobin of 9.2, which would be anemic in a normal person, but 50% of her hemoglobin is methemoglobin. So she has a functional hemoglobin 4.5, I guess. So clearly is going to have some shock issues in that scenario in terms of oxygen distribution. And then the jaundice, I'm assuming, do you have a bilirubin? I'm sure it's through the roof.
They don't give me a bilirubin.
No. Well, I mean, I'm saying that because I think it would be reasonable that maybe hemolysis is occurring here, and that's where the elevated T bilirubin would be coming from. I mean, I assume it's elevated if they're jaundiced. Whatever she took is inducing methemoglobinemia, probably has excessive oxidative stress, and then is hemolyzing. So now we're seeing hemoglobin spill from the red blood cells, get metabolized into or conjugated into bilirubin. Now we have hyperbilirubinemia. The potassium of 9.3 on day 2 could also probably be from hemolysis. I mean, we get hemolyzed samples all the time, and potassium's through the roof. Do they mention EKG changes?
There are no EKG changes.
That's surprising. I mean, if you hemolyze blood in your tube, that's not a problem. If you hemolyze blood in your blood, that is a problem. Now, with a history of chronic UTIs, well, okay, first, it's not that normal to be on an antibiotic for UTI prophylaxis. It's not generally recommended. And I don't know of any antibiotics that cause methemoglobinemia reliably. But since I know I have to guess a toxin, and I know that phenazopyridine is generally associated with causing methemoglobinemia, and somebody who has chronic UTIs might chronically be taking phenazopyridine, which isn't to treat or prevent infection. It's to treat dysuria associated with a urinary tract infection. So she might have them frequently and frequently need to take it. So I'm going to put that high on my differential. So drugs of abuse, meaning used for euphoric effect, not in its intended manner, I would be considering inhalants. 52-year-old female, but who knows what they like to do. Certainly didn't. So the inhalants I'd be worried about would be the nitrites. So poppers you could buy at a gas station. You fill a balloon up with them, you suck them in, and then you get hypotensive and you get a little dizzy, and apparently it's fun. Known for their vasodilatory effects, which have made them popular at certain raves and things like that. But if she is abusing a substance, I'm going to be more leaning towards the poppers. I guess we could check her well water for gram-negative bacteria to see if they're making nitrites. I guess that's only for kids, huh? Never mind. Did she get methylene blue?
She did. You want me to read the rest of the...
Yeah, drop some more in there.
Okay. She remained confused, tachycardic, and hypertensive with renal insufficiency or brownish urine. She was given a total of 5 milligrams per kilo of methylene blue.
Wow.
With a repeated methemoglobinemia, methemoglobin level of 26.4%.
Huh. And I guess my next question would be, this would help me narrow down what the toxin is.
Mm-hmm.
So first off, that's great. Did they give me any ethnicity? Caucasian, African American?
No.
So I always worry about giving methylene blue in G6PD deficient patients, because it's not methylene blue that actually does the reducing of iron. It actually is just more of an electron shuttle, where it'll take an electron from something, usually from electrons or reducing power that's built up by G6PD.
Yep.
So methylene blue will actually take an electron and then shuttle it over to your oxidized ferric iron and reduce that. But if you don't have any of that reducing power because you're G6PD deficient, you can actually end up stealing an electron directly from iron and oxidizing even more iron. And you can actually worsen hemolysis, or you can either cause hemolysis or worsen your methemoglobinemia, at least in theory.
Mm-hmm.
In which case we treat those people usually with high-dose vitamin C. Now, usually if you're taking an oxidant and it's an acute exposure, it oxidizes and goes away, you should only have an elevated methemoglobinemia for, the duration of time until you treat them with methylene blue. But if it rebounds, you might be dealing with a highly fat-soluble agent, like some of the aniline-derived herbicides, or even benzocaine. And dapsone, I do believe, can cause a prolonged Could she be on dapsone for the UTI? No, that doesn't make any sense. So I'm still sticking with azo because the only clue you gave me was chronic UTIs. So.
And phenazopyridine is the correct answer.
Wow. All right. Wow. Interesting case. Sad outcome. The dangers of UTI overtreatment.
On day 2, she, like you mentioned before, with her shock, she was started on norepinephrine for hypotension. Ended up receiving an exchange transfusion, I'm assuming because they were already pushing their dose of methylene blue. And then unfortunately she died during transfer to a tertiary care hospital.
Oh man, that's rough.
Yeah.
That's wild though. 5 mg per kilo is definitely pushing the dose. I think 7.5 mg per kilo is where a lot of people cap.
Now, I only ask this because they don't give us this information, but what if she was 130 kilos and they gave her 5 mg per kg?
I do not know what the volume and distribution of methylene blue is, but
well, antidote dosing and obesity is one of the.
It's likely. I gotta imagine it's pretty water soluble. I think I would err. Well, you know what? At least you have a drug that you can directly measure your effect on, so you could just give until you see a reduction in the methemoglobin.
They got a reduction.
Or they develop serotonin syndrome. One of the two.
Yeah, they got a reduction. It was just not, wasn't as pronounced. So did they give too much methylene blue, which ended up, if her ideal body weight was 65 kilos, they may have given her 10 mg per kg of methylene blue based off her ideal body weight.
Yeah, that's fair. Are you supposed to do it on ideal?
I don't know. That's why I'm asking.
I guess its effect is limited to the blood, kind of like heparin. So
yeah,
in theory, you don't need as much because your blood volume doesn't increase with your body size 1-to-1. But you would get drug steal probably into other compartments. I don't know. That's one for the rabbit hole, Matt. Okay. A 38-year-old male was found in a car partially off the road. They had previously threatened police about having chemicals in the car which could kill them. A haze was seen in the car and a note on the window was placed. Past medical history of substance abuse, previous suicide attempts. The clinical course, on arrival, EMS found the patient deceased. Autopsy noted skin had a faint bluish-green discoloration. And at the time, post-mortem subclavia blood demonstrated a thiosulfate level of 9 milligrams per liter. That's all I can really give you.
So, if we're dealing with chemicals in a car, I am going to surmise that this was an inhaled toxin, most likely. Every time someone thinks of cars and toxins in cars, I think most people would think of carbon monoxide, which is possible, but the note on the car would make me feel like that is not what this is going to be. There was what you mentioned something I think that might give me an idea. I think it was a bluish green
green discoloration of the skin.
On the skin. So when I think of colors on skin, a bluish green, this wouldn't be something like borax, which can cause blue-green hematemesis or blue-green emesis and
Christmas toxin.
Yeah, and red skin. I think of hydrogen sulfide, and again, we're dealing with an inhaled toxin here, so I wouldn't imagine it could be sulfuric acid. Granted, you would need, if you're making hydrogen sulfide, you might need sulfuric acid to actually make hydrogen sulfide. And again, if you have a high enough concentration in a tightly enclosed space and you're in there long enough, your soak time, you could definitely have some pretty significant effects. I would imagine there would probably be some other physical exam if it was just very caustic.
Essentially being bathed in
there should be some other physical exam findings if you're bathed in a caustic. But, when you think about hydrogen sulfide manure pits or sewer gas, it's a knockdown gas. So even, high concentration, short period of time, even if you're not inside something, you could probably see this knockdown effect. So maybe that's where the warning came from with the note. So I think my guess is going to be hydrogen sulfide.
That would be correct, sir. So hydrogen sulfide, I mean, how different from cyanide are we really talking here? It's got measured thiosulfate levels. Now, it's funny, sodium thiosulfate is a treatment for cyanide poisoning because cyanide will get conjugated to sodium thiocyanate and then urinated out. When the hydrogen sulfide exposure, you actually make thiosulfide as part of the metabolic pathway. So you can use that in some cases to confirm exposure. But yeah, so he was threatening police about having chemicals in the car, which could kill them. There was a haze seen in the car and a note on the window that said, warning, hydrogen sulfide. So this is all part of the increasingly disturbing detergent suicide trend that's been going up. It's kind of started in Japan, honestly, and has moved on, found as I think information about these substances has increased, people have caught on. So it's a cellular asphyxiant. So hydrogen sulfide actually binds to cytochrome oxidase and prevents electron transport that allows us to utilize oxygen for energy production. So even though you might be delivering oxygen to your tissue absolutely fine, your tissues can't use it at all. So you suffocate on a cellular level and cause global tissue death. Very difficult to treat. There's some pretty interesting antidotes I know that people have looked at. So you can induce methemoglobinemia just like cyanide. I've seen case reports of hydroxycobalamin, cobinamide, that novel antidote for these cellular asphyxiants has definitely been looked at. Pretty fascinating stuff.
It is.
All right, you want to do one more?
Are you ready?
I'm ready.
Okay. Yeah. This is a tough one.
I'm ready.
All right. 33-year-old male was found in a PEA arrest after reportedly ingesting a rat poison.
Okay.
Containing this substance. EMS achieved ROSC. Naloxone was administered without response. His ABG showed a pH of 6.86, PCO2 of 38, PO2 of 576.
That's a post-intubation ABG, I assume.
Yes. Potassium 4.5, CO2 of 8, BUN of 28, creatinine 1.64, glucose 178. They gave you the anion gap too.
What's the gap? 40.
AST of 122, ALT of 130, INR of 1.9, CK of 1752. Lactate greater than 20.
So gap of 40, lactate of 20 makes sense. INR is 1.9 and he ate rat poison. So I'm dealing with probably 4 or 5 different possible scenarios. So this is probably either, well, the INR of 1.9 is, rat poisons, we're looking at, long-acting anticoagulant rodenticides, which we see a little bit less often these days, unless they're, contaminating synthetic marijuana. We have zinc phosphide, which is super lethal, and that's probably what this is. Bromethalin is a possibility, but depending on when he ate this rat poison, I don't think I would see effects just yet, as bromethalin needs to be metabolized to desmethylbromethalin to see the real toxicity from it. Other options would be vitamin D, which would manifest as hypercalcemia, and I don't think we would see this. While I would be led astray with the INR of 1.9, I think it's actually related to shock liver from his cardiac arrest. So I'm leaning more towards some kind of a cellular poison, but let's keep listening.
All right. A patient was sedated, paralyzed, and intubated, received IV fluids and sedation, but exhibited intermittent jerking movements. Lactate normalized on day 2. His CK increased to greater than 20,000.
Oh.
Despite treatment for the rhabdomyolysis, his renal function deteriorated, required hemodialysis on day 5, and then a poor prognosis, and the family opted for comfort measures. He died on day 9.
Interesting. I mean, there are a few other things And maybe we didn't address. Hold on. Is strychnine still something that they're using? Do they have what opisthotonus? Are they doing a backbend?
It doesn't say. It just says jerking movements.
Jerking.
Intermittent. And this was it says sedated, paralyzed, intubated.
Nothing about the CT of the head.
They don't say. But he exhibited intermittent jerking movements. That's
neural injury. People have jerking movements all the time. So not that. Especially if you're sedated and paralyzed. Well, and not paralyzed. Gosh, I'm trying to go back. I'm reaching. None of them are inherently pro-seizure that I can really think of. Obviously, many of them have neurologic effects. Was there any green, vomit, or stool?
No.
All right, I'm going to use that to help rule out bromethylene.
I'll even give you a hint. They give me the percentage here. So it's whatever the substance is, it's 0.5%.
0.5%? Mm-hmm. Well, that makes me think it's brodifacoum. Because isn't that usually 0.5%? Bromethylene's usually 0.1%. All right, I'm torn. I swear, I could just be losing my mind, but I swear there's still strychnine rodenticide somewhere. Or maybe I'm just making that up. Things are just blurring together.
Well, there's still, it's not necessarily whether they're available now. It's that they're just bought 30, 40 years ago.
Yeah, but now I can't even remember if those were used regularly as a rodenticide. I'm going to go, well, all right. They ate it, they swallowed it, right?
Ingested.
It didn't rain beforehand. All right, it's either zinc phosphide or it's strychnine.
Do you want me to tell you?
Yeah, I want you to.
It's strychnine.
It was strychnine? Wow. Oh, kind of a bummer of a case. That poor kid.
Yeah.
I can't believe I got that, though. I guess I should. Well, all right, 50% got it. It's such an old toxin.
Yeah, it's an old rat poison.
This is why toxicology isn't fair, because even when something becomes totally old and outdated, someone will find an old bottle of it and try to take it. That's like a once in a lifetime poisoning. Is that even around still?
I don't know. Maybe it's still available. Probably only via commercial licensed exterminators, I would imagine.
Yeah.
But you remember, it's a glycine receptor antagonist, and glycine is one of the major, actually, inhibitory neurotransmitters in the spinal cord. So if you put a glycine receptor antagonist on board, you're gonna get excitation, which essentially leads to this spasm. And it looks like seizures. They could be, if someone has a normal mental status, it could be more of maybe a conscious seizure, for instance. It's almost indistinguishable from tetanus.
All right. The infamous spinal cord fracture from severe tetanic contractions from strychnine.
Yeah. Just the tetanus. The tetanus mechanism is preventing the presynaptic release of glycine, right? So it's more of an indirect glycine antagonist versus being a direct glycine receptor.
Fascinating. Yeah. From the Nux vomica plant, if I believe. Strychnine Nux vomica. Yeah. I surprised myself there.
that was good.
I'll put the little clap emoji there. All right, that was a good time. You know what we need to do? Every Thursday, we just need to get the residents together, and we need to have a little case conference with these.
For sure.
And that'd be great.
I think that'd be awesome.
Yeah. All right, man. Well, any final thoughts you want to leave before we close this episode?
I think one of the things, just when you think about all the cases, at least the ones that not the ones from Ask Drugs, but I think the biggest thing is just to keep an open differential when you hear of some of these things, because not every case, there's a lot of nuance around some of these, and not every case fits into a nice little bucket of a problem. So history is important. And
well, even with the history, half the time we don't know what we're treating.
Exactly. But regardless, Frank Polachek said it well. The history and the toxidrome kind of give you the poisentation of
the poisentation. I like that.
We're trying to.
But
good. Toxidromes aren't perfect, so it's good to keep cast a wide net for a lot of these.
Absolutely. All right. Well, appreciate you being on the show, Matt. I'm sure you'll be back on soon.
Good time. Can't wait.
All right.
See you later.
Wow, Ryan, what a great show today.
Thanks, Toxo. All right, Poison listeners. I think that'll wrap it up for today. I hope you learned some interesting things. Drug testing, alkyl-piperidines, 5-HT2A partial agonists, rat poisons, methemoglobinemia, and weight loss supplements. I think we covered a lot. Now, remember, today was just two nerds nerding out about toxicology. We tried to make as much of it evidence-based as we could, but we were just talking about a lot of theories. But we were happy you could listen along with us. Don't forget to send in your guesses for our next episode. You can find the toxins that we'll be talking about either at the end of episode 4, which was just before this, the rise of lethal loperamide, or you can go to our Twitter, @labpoison, or our Instagram, @tox_talk. And if you think you know what the poison might be, send your guess to toxtalk1@gmail.com so you can participate in the next episode. Be sure to say who you are, where you're from, why you listen to the show, and more importantly, why you think the poison is what you think it is. Thanks so much for listening today. Hope to see you next time. Hey, Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Please contact your doctor for any health questions or call your local poison center at 1-800-222-1222 for poison-related questions. The opinions expressed on this podcast do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Subscribe for future episodes and don't forget to share with your nerdy friends. See you next time. Goodbye.